non-professional, and that sounds a negative, but I won't call myself a service user because that sounds passive, and I'm not, believe you me. Not now, I was at one stage. So that's me, Tony Bonser, and I'm a trustee of the National Council of Palliative Care. I've just been made a trustee of St Catherine's Hospice up near Preston, where I live. I'm a local champion for the Dying Matters Coalition in the North West, and I'm a fundraiser for Macmillan Cancer Support, all of which sounds fantastic, so I'm almost on a level with you. Except, of course, that's what I do. It's not who I am. And who I am is very different, and who I am, I think, is really important. Because who I am is Neil's dad. And this is Neil, age about 13. Neil was born in 1973. He was diagnosed at the age of 31 with a sarcoma on his right thigh in 2004, and he died on March the 4th, 2009, which means that Tuesday is the 5th anniversary of his death. And I thought it was going to get easier, and it doesn't actually, it gets different. But during the intervening 5 years, I've thought a lot about what happened during those 5 years of his illness, and what's happened to us as a family and what happened to him. And I have to say now that we believe the medical care he got was second to none. We believe that from the moment of first diagnosis, the outcome was never in doubt. But we have problems. We have problems about communication. And I suppose what I want to start off by saying is you've seen all the qualifications, so to speak. But what I am is Neil's dad, Dorothy's husband, father to Sam, who was Neil's sister, and a unique individual. There is nobody quite like me. And that's true of absolutely everybody you ever meet on a professional level or any other level as well. And that's why I sometimes get a little bit concerned when we're looking at treating everybody as though they're the same. I was at a big meeting with a lot of senior clinicians recently, and somebody said, we've got a family strategy for bereavement. Actually, there are no families, there are individuals, and every individual reacts differently to situations. I'm going to show you a slide now which has a cartoon on it, and it contains a picture of a Macmillan nurse, which is like no nurse I've ever seen before, honestly. But I use it because I can't cope with real pictures. The memories are still a bit too heavy. But this was an absolutely turning point, and this is what got me involved in what I do. This was the day before Neil died, and we didn't know that, by the way. Nobody had told us in words that we understood. There were all sorts of hints dropped about the fact that Neil was dying, but nobody said, your son is dying. And since it doesn't happen to 34, 35-year-old boys, we didn't believe it. But we were summoned to the hospital where there was, I thought, myself, Dorothy, Neil, a Macmillan nurse, the ward sister, and the consultant there. And the first question was from the ward sister to Neil, and she said, what do you want now, Neil? And Neil said, I want to go home. He was very proud of his own flat in the centre of Preston. And 16 hours later, he was back home. This was 2009. The National End-of-Life Care strategy was in place, brought in 2008, and I think he was one of the first rapid discharges. It's only just occurred to me in the last few months that that was the case, but I think it was. And it's because of that, and because somebody actually worked out what he wanted and made it happen, that I'm now campaigning for just that, for looking at patients and find out what they really need. Go on a few months, a couple of years, and I was in a room rather like this with a whole lot of senior clinicians and some politicians, MPs of different parties, and one or two people like myself who were just service users. We were discussing how you integrate social care and medical care. Wish we'd found a solution, but at one stage the conversation got hung up in a discussion between the MPs about what to call the committee they were going to constitute to look at the matter. And it went on for half an hour, and I got very impatient because I don't think the committee was ever formed, by the way, and certainly that group for that day never got anywhere as far as I know. But it just struck me, I sat there and thought, this is just wasting time, because in actual fact, there are only two questions, and can I just highlight this for you? There are only two questions that matter to patients and carers when we're talking about changes in end-of-life care. The first one is, how will this improve my life? And the second one is, how soon will it happen? And that's why I get impatient, and I now have the courage to voice my impatience. Because that really matters, and sometimes we can do a research project and think, wow, aren't the results fantastic? Yeah, they are, but until they reflect in somebody's life, they haven't got anywhere. And we can actually stall at the point of saying, we've analysed the results and we found out some wonderful things. So it really is important that we get things right. And to do that, we need to know what matters to people. Can I introduce you to Lee? I work for my local hospice. I take people in for daycare, and I took Lee in for about a year before she died, a year last November. She was a retired nurse. She had cancer. She knew it was progressing. She knew she didn't have long to live. She was very proud of her own flat, very small sheltered accommodation. But she was worried because she knew that things were getting a lot worse. And she rang her doctor and asked him to make a home visit. Now, she had a love-hate relationship with her doctor, as she did with all sorts of people, including me. The first discussion every Friday morning when she got in the car was where I was on a toy boy list. And that depended on how well I'd behaved myself during the previous week. But she asked the doctor to come around and said, "Doctor, I know my condition's not improving. What's going to happen to me?" What she wanted to know is physically, emotionally, psychologically, what was going to happen over the next few days, weeks, months. What he said to us, "Don't worry, you're going to live to be 100. He made an assumption about her values which was totally wrong. She got rid of him and phoned me and said, "Tony, come round, I need to talk." She said, "Why doesn't that man understand? I know I'm not going to live to be 100. By the way, she was very anti-monarchist. She thought the Queen still sent telegrams and said, "I don't want a telegram from that woman." But she also said, "What I want to know is, can I stay here where I'm comfortable? Can I have my friends around? Can I have the right people around me towards the end of my life?" He'd misread it seriously, and that was a problem for her. And yet, when we get it right, and I think one of the things I want to say to this study is, can we talk about communication? Because it's so much central to everything else. You don't find out what you need to find out without communicating, and you don't get what you're able to provide over to the people you're dealing with without communication. So can I introduce you to Tess? This is Tess. She died a few months ago. My wife took her to the hospice. A lovely lady. She also had cancer all through her body and knew things were getting worse. And a consultant, she had a wonderful relationship with a consultant. They were able to be totally honest. He knew where she was, that she knew she was near the end of life and was okay about that. He knew what mattered to her, and she trusted him. So they did a biopsy. He called her back in. He sat her down, not face to face, but in two comfortable chairs next to each other. He didn't have a computer screen. She sat there and he put his hand on her hand. And he said to her, "I've got the results back." She said, "Yeah, I know." And she knew her own body. She said, "I know what they're going to show. It's progressing." He said, "Yeah." And he said, "I'm quite worried. Things are not looking good." She said, "Yeah, I expected that." And he said, "I could operate. We could try and remove the tumour or some of it, but I don't want to operate in view of your blood pressure and heart." Her blood pressure was all over the place and her heart was in a very bad state. "But I will if you want." And because she knew him, she said, "I know what you're worried about. You think you're going to lose me on the table, don't you?" And he said, "To be honest, yeah, it's a distinct possibility. And even if I operated, I can't guarantee it would improve things." But he said, "There's another choice. I can change your medication so that you'll feel better and more comfortable." And then he said, "It's your choice. You can decide. If I change your medication, it won't prolong your life, it might even shorten it. But you might be able to go out again and shop and have meals out. Your son might be able to come over and see you from New Zealand." And she made the decision and she said, "I'll go for the medication." And I have to tell you this story. Her condition improved. She was able to go out, she was able to have her meals out, her son came over, but eventually it worsened as she knew it would, and she became an inpatient at the hospice. And we were privileged, Dorothy and me, to be allowed to visit her. And she's lying there in bed 2 days before she died, and her son, who'd come over from New Zealand, noticed that her lips were a bit cracked, and he said, "Mum, would you like a drink?" She said, "Yes, please." He said, "Shall I make you a nice, warm cup of sweet tea?" She said, Tess had a very dramatic way of showing when she didn't like something. "Bleh!" He said, "But Mum, you love warm, sweet tea." "Yeah, I don't want that." He said, "Mum, what do you want?" She said, "Beer." He said, "Mum, you've never drunk beer in your life." She said, "I know, I want to try it before I go." And can I tell you something? That was important because she smiled about that, and that really mattered to her, and it mattered to her son because he'd found out what she wanted and made it happen. And it matters to me and Dorothy because I have a warm feeling now just telling you about it. You see, communication is really central. And I want to take you back to that slide with the nurse who said to Neil, "What do you want?" And I've told you what I think happened then. Now, November the 10th last year, Neil would have been 40, and we went out to the creme, Dorothy and me and Sam, and then on for a meal. And it was at the meal, nearly 5 years after Neil died, that Sam said, do you remember that meeting we had with the consultant and the Macmillan nurse? And we said yes. And I suddenly thought, hang on, Sam wasn't there in my memory. I got a perfect visual memory of that. I could tell you where everybody was in the room, but she wasn't there. I had edited her out of the memory completely. And then she said, do you remember when that nurse said, I don't think anyone's told Neil he's dying, somebody had better go and tell him. And Dorothy and I looked at each other. We neither of us remember that at all. We had edited that out. And that shows something important about communication, which is basically, as professionals, you may well know what you've said, but you don't know what I've heard. Because I'm often in a highly emotional state, and what I receive from you is what I can receive, what emotionally I'm capable of coping with, and if it doesn't fit with what I'm able to cope with, I will edit it, and I will know that I'm right. So that's what really happened at that stage, as far as I know, and it's taken me nearly 5 years to understand what really happened at that meeting, which was key to everything. And I guess that I would like this clerk to look at, among other things, the way we communicate, the way we find out what people's values are. Because in stressful situations, people don't hear, see, or remember what you think you've said or done. And it's not enough to say, but I told them. You need to make sure that they know. You need to cross-check. You need to give people time to absorb and to ask back. When Neil was first diagnosed, we were all called to the hospital, and the registrar, who was pinching 5 minutes out of his lunchtime, told us that Neil had a tumour and that it was a rather aggressive one, and then said, any questions? There's a nurse around somewhere you can ask. It was 2 days before the real questions emerged, and somewhere in this process I would like some work done about how we work with communications. You see, for everybody you meet and deal with, their perceptions are valid for them. They may not be an accurate reflection of what happened, but they're valid for them, and they may affect the whole of the rest of their lives. And I'm really concerned, because I spend a lot of my time with people near death and people who are grieving, that we don't pay enough attention to that. We are leaving people to cope when they often can't. And we come from a culture which says, once the funeral's over, it's okay, isn't it? Stiff upper lip, you'll manage. People are not managing. So finally, what would I like to come about? As a result of this, this is my wish list. Can we try and research meeting real needs, not perceived ones? I was working with some students at a multidisciplinary training session at Brunel University recently, and we had a little scenario, half-page, written by a man in his early 40s with motor neurones disease. He had a partner and 2 sons, teenagers, one young teenage, one moving on to further education. And his paragraph started, I'm starting to have trouble speaking and eating. The rest of the paragraph was about his partner, his worries about money, his worries about how the family stuck together, his worries about his son's education, and the last bit was, and I am the head of this family. And the group were discussing what they should do. First of all, well, we'll get in a speech therapist. We'll get in a dietitian. And I said, but what's this man really worried about? Well, he says he can't speak and he can't eat. But I said, but what's the rest of the paragraph? He's worried about his family. He knew he was dying. He knew he wasn't going to get better in that respect. He wanted somebody to support his concerns about the family. We need to meet the real needs, not the perceived ones. And part of, I hope, of this clerk will be about how do we find the real needs. Let's focus on the person, not the condition or the diagnosis, because every person is different. That comes back to the fact that I am unique as you are. Let's restore control. I'm really concerned that people towards the end of their lives feel that all their choices are reduced. They have no part in the discussion. People do things to them. People decide where they'll be, what they'll eat, what they'll wear. And families and carers who may have looked after them intimately, closely, for days, weeks, months, maybe even years, are suddenly cut out of the equation. And I hear complaints from all sorts of people saying, but it really matters. Even if I just want to moisten her lips or I want to wash her occasionally, but they've shut me out. They are part of the equation. You're not dealing with a patient, you're dealing with the cloud of people around them. And we need to restore that control, that sense of ownership of their own life and their own destiny. We need to help to achieve a good death, and that is partly, and I know I'm preaching to the converted, trying to explain to people that a death is not a failure if it's a good death. A bad death is a failure. And I keep hammering this point over because we have a health service which counts making people better as the criterion and making a good death as some sort of failure. And lastly, let's not forget that when anyone dies, almost inevitably, there are a group of people who are emotionally connected with them, who are having to cope with the loss of that person. And despite our British culture, it's not easy and it won't be done without help. Those are my wish lists. Thank you very much.